Okay. Thank you. Okay, thank you, hon. Okay, so I can definitely record. Yeah, and so right, what was I saying? Yeah, so I had to reach out to Professor and Dr. Dunker to make sure that because I didn't know what the school was doing, so I didn't know if they were canceling classes. They just sent it while I was here. As you can tell, I'm in school because I said, just in case, let me try the road, see what's happening, be on site. And my internet connection is not as great at home either, so I didn't want like connection to cut off if we were going to be online. So that's the story on that, which worked out okay because we actually had an extra kind of class. So hopefully everything's okay Wednesday. And I also wanted to contact Professor Susan as well to make sure, because I think you guys have an exam on Wednesday and I didn't want two classes to be giving you an exam. So I wanted to see what she was going to do. And thankfully she had decided to push her class. She decided to push her class because I was going to put mine on Wednesday instead. So that worked out. And I also didn't want it to affect her if I had all of you come and be on Zoom and then her class is after mine. So I just wanted to coordinate and be respectful to others and also you, just to make sure you're not affected too grievously by this situation that we cannot, I guess, what is it? What's the word I'm looking for? We can't control. All right, so let us get to, I'm not teaching today, so to speak. I'm doing a review, so I want you guys to ask me questions, okay? So that I can explain, and I want us to have a conversation. That's kind of how I wanted to have it in class. So if you're asking a question, you could definitely raise your hand or unmute yourself. And I want us to work together, right? Answer each other's questions, and I will chime in to direct and correct. But I want this to be a help to you so that you can kind of expand your understanding. So this would have been where I had this game where we were going to, actually, I think we can still play because it's still kind of like a review session. Just, let's see. All right, let's try and see, because I think if I'm the one telling you, it's kind of the same thing as being in class. But if you're the one putting it in your own words, then it's helpful for you to kind of like see what you know and not just sit there and listen again, because you did that already. And so this is a review. Okay, so let's do this kind of like what we were going to do next week. Okay, so I am going to put up a word, right? And someone is going to tell me what comes to mind, everything that comes to mind when they see that word. Okay, so let us do that. Okay, so this is a concept of perfusion. Okay, so when let's see, this is not how I did it in class, because let me see how else I can do it to make it. I guess I'm going to have to do it this way. Let's see how this works out. So I have here cardiac output. So can someone let me know all that they know about cardiac output? What comes to mind when you think about cardiac output? Cardiac output.
Cardiac output, heart rate times stroke volume, preload, afterload, contractility, all that good stuff.
Okay. What else? Anyone else? Yep. I see Sue Young says it affects SV and heart rate. Yep. Stroke volume, heart rate. Yep. Anything else? Yes, blood flow to the body, right? I love that. Increased heart rate, increased cardiac output. Love it. Yeah, John is here. Okay. Anything else? Increased heart rate, increase vice versa.
What about oxygenation?
Yes, I love it. Oxygenation. So what happens about oxygenation with cardiac output? How is it affected?
Well, if the blood's not flowing, it's not bringing oxygen or removing carbon dioxide.
Love it, love it. So kind of when we start talking about the peripherals, right? If we don't have good cardiac output, right, Deanne, and that artery is not getting the oxygen to the toes, we're going to have necrosis. We're going to have possibly problems with healing. Very good. Very good. Love it. Good job, guys. Affects the heart rate, preload, afterload, and contractility. Yes. So now it's affected by and it affects. So it's affected by contractility, but it affects heart rate. It affects, it's affected by preload and afterload. Definitely, definitely. So here's another word. How about,
I can ask for more.
yeah, go ahead. Add some more.
Like diet, we have medication that, like I think calcium channel blocker,
Yeah, definitely.
diuresis, because
Yeah.
diuresis, deals with preload.
Mhm.
Calcium channel blockers, I think, deals with the contractility of it.
Yes.
And
Yeah.
beta blocker deals with like the heart rate and the contractility too.
Good.
So,
Good. Love it. Love it. So it's important to know which medications affect what, because when we have a problem, we have to know, okay, which one are we going to give to affect the contractility, right? Are we going to use digoxin because that affects contractility? Are we going to use beta blockers, or are we going to use diuretics? Are we like which part of this cardiac output problem, since all of these are affecting it, heart rate, preload, afterload, contractility, which one is being affected the most and which medication is going to help this problem, right? Great on, thank you. So let's talk about stroke volume in particular. Tell me a little bit about stroke volume.
stroke volume is like the amount of blood coming out of the ventricle after it comes. You have like ejection fraction that tells you whether the heart is pumping sufficiently enough.
Yeah. So that's important because when we think about it, we're like, okay, so how much? I know cardiac output is coming. I know but how much is it, right? So the amount is calculated by the stroke volume, right? Good job, guys. Good job. Anything else? Anyone else? Go ahead.
I got I think the pulseless electrical activity thing, the PA thing.
Yeah.
I think the heart can pump, right? But if there's no blood going out, then you don't have a pulse in the extremity at all. And talking about blood, stroke volume, it needs the dilation, right? We need the dilations to like get the blood in. So if the heart too fast, I mean, we have a stroke, but we don't have anything to like pump out.
Come out, right? And that's and sometimes even when you say, why are they using so many different words to mean the same thing? Well, there's different parts of that structure or the functionality that they're identifying, and it makes sense that it's affected, right? So yes, we have cardiac output, but how much is being left behind, and those things matter, and that kind of help us realize what the problem is, right? How about if I say absolute, what comes to mind?
Absolutely.
What absolute? I know it's kind of the refractory period. Good job, Melissa. Tell me a little bit about that. Mariah says, cannot accept another impulse for depolarization. Yes. So we talked about the heart being all or nothing, right? And there's a certain limit where it will not be able to send a signal, and the heart won't receive it, even if it did, but it can't, because that's just how the action potential, the signals to the brain, that's just how it works, right? And so what's the other word that's connected to that? We have absolute and we have? Relative, right? So that's the one where it's like right at the end, we can get something. And that's usually when all these other extra signals happen, that's when they usually can come in and cause the heart to send these extra signals, beat faster than they should. Okay, good job, guys. All right, how about if I say electrocardiogram, what comes to mind?
I don't know.
Measuring the heart's electricity action.
Yes, conduction system, that's right. The electrical system, right? The EKGs, we're thinking about that. So when we're seeing how the PQRST waves are functioning, that's what's telling us the electrocardiogram, right? That's what that's calculating. Yes, electrocardiogram, yes. ECG, right? ECG.
Okay, now I know, because I was like, what the heck is that?
Right, it's a ECG. That's what that EKG, ECG, same thing. So that PQRS wave, it tells us what's happening. And there's something I did mention in class that I just want to mention. All right, and one of the okay, you guys. So here's the thing. So I have if we come off because I have the non-paid Zoom, just stay on and then I'll come right back on because we don't use Zoom, but this is the one I know the best. I don't know Teams as well. So I'll just stay on and I'll come right back on the same link. Okay. All right. So right. So then yeah, so when you're measuring the PQRST, sometimes we have what's called oh shoot, the word was in my head and then I forgot it. Oh shucks, darn it. Refract, nope. Okay, I'm going to say what it means. I can't remember the word, right? And you're not going to be tested on it, but it's something good to know, especially if you're going to work on the heart unit. So when you put the leads on, whether it's the 12 leads or it's just to monitor the heart, you might have because they have hair or because they're moving, there's this staticky thing, artifact. Thank you, Mariah. You have this staticky thing that shows up and it looks like, oh my gosh, the person is going into let's say fibrillation or VFib or atrial fibrillation or atrial flutter, but it's not. It's because they're moving. So always make sure. So what is the one thing? Let's say you're in your office or you're in the nursing station and then you see that alarm thing go off, that, oh my gosh, the person looks like their heart rate is going off. What do? Check on the patient first. That's right. You always want to go in and look at the patient. And that's with everything, you guys. Always remember, whether it's an oxygen, whether it's a PEEP flow meter, it's a telemetry, whatever, or a J2 PEG, whatever is connected to your patient. If there's an alarm that goes off, you never want to check the machine first. You always want to check your patient first. All right. Okay. Here's, okay, let's see. How about when I say renal dysfunction, and now we're talking about hypertension, what am I talking about? What comes to mind when I say renal dysfunction in relations to hypertension?
RAS system.
Okay, RAS system. Okay.
Trina said that. I give credit to Trina.
Okay. Oh, so Trina says RAS system. Kenneth says poor perfusion in the kidney. Trina also says ADH, nephrosclerosis, right? So there's so many different things that can happen with the kidneys that can cause it to malfunction. But when it malfunctions, what does that mean? It says renal damage due to increased perfusion. Is it increased perfusion though? Maybe increased blood pressure. Yeah. Oh, thank you, Elliot. I read, I read perfusion, but you said pressure. Sorry, Elliot. So increased pressure, so high blood pressure, definitely. So, but then I kind of gave it away. Then, so that means sometimes there's going to be decreased perfusion there, right? And that pressure is going to cause damage, and it's going to die, and it's not going to work properly, and we're going to have problems. So, secondary hypertension can occur, right? What else can happen? What other things can happen when there's damage? Renin, yeah, definitely. Patient says renin won't be produced, but that's part of the pituitary sending signal. So even if it's produced, it might not work, right? So we have kidney failure, we have hypertension crisis, we have ESRD, yes. So all of that. Red blood cell production. I love it. Who said that? Trina, good job. What is that called? What happens there? Yes, epigen. Elliot, that's right. So when we have, sorry guys, I get too excited, right? I'm getting too excited. I see your face. Mika, I see your face. All right, so, but good job, guys. It definitely, when the kidney fails, there's a lot of things that we have to consider that's going to happen, right? We're going to see that the urine, what about, no one mentioned urine. What's going to happen to urine, right? What's the end result? Decrease urine. So it might first is going to start with increase and then it'll decrease, right? First, like the doors don't know how to work and they all open up. There's like, that's it, everybody out. And then it's like, oh no, this is happening too much. And then it closes, then it shuts down, and then we have kidney failure. Good job, guys. All right, let's go to something different. Let's go to PVD. I'm going to go jump back and forth. Okay, so let's do varicose vein. What do you think about when you see varicose veins?
She said CVI.
CVI? So what does that tell us?
blood stagnates, blood doesn't go back, so blood is there.
Damage to the vein, right? Vascular issues. I see Melissa says, Kenneth says damage to the vein, high risk for DVT. Nina says, then we have edema, says Su Young. Secondary lifestyle, sitting or standing a lot, right? There's some things that can happen that can cause this to happen. Return problem, we don't have blood returning back to the heart. Brown skin ankles, right? That blood, there's dirty toxic blood sitting there in the toes, right? And all of those are vein issues. But if we say, well, we are talking about veins, but varicose veins, what's the symbol? Like I see edema, pooling of blood. So what is it gonna look like? Warm feet, yes.
Enlarged, it looks like
enlarged, yes.
like
So
weird.
we can definitely have the edema, but what is symbolic of varicose vein is that enlarged, discolored, like you can see, like usually you don't see blue. Like it's like a little line of blue, but it's protruding and it's enlarged because of that distension. Yes, Su Young, the distended vein is what is that iconic, right? And there's going to be rerouting and Melissa, ooh, your wording, girl. What's that? Those two words up there, I don't understand. But ROPEY, tell me what that means exactly. A rope. It looks like a rope. Okay, it looks like a rope. Okay, it looks like a rope. It does. Tortuous rope-like veins. Now, and the only other thing I could add, which is just that to fix it, it's not a problem. It can cause pain for some people, but it's not for everyone, and it could look ugly, and so it's an elective surgery, and they'll do ablation, kind of cut out the circulation to that area. They could even take it out, but it's elective. It's not a horrible something that, okay.
Can we give him like anticoagulants to like prevent DVT? Aspirin, heparin?
I've never heard that, truly, to be honest, about varicose veins, because yeah, I can see that as a possibility. Now, if it's going to cause DVT, yes, but I have never truly seen someone with varicose vein placed on anticoagulants. I have obviously seen people who have a risk for DVT placed on anticoagulants, and if it's painful as well. So it depends on the person's symptoms, and it depends on their risk factors, right? So yes, a risk for phlebitis, definitely. Okay, and ulcers. Okay, now let's talk about this. If I say the word ablation, what am I talking about?
You, with a heart, you.
What happened to me, right? What I had to do. But what was that? Catheter ablation, yes, definitely. AFib, aflutter, but it's not just AFib or aflutter. For our purposes, it is. But it's what are they ablating? Removing cells? Not removing cells.
We're burning them, like
burning them. Yes, burning this area. They don't cut anything out. They just burn it so that it removes the ectopic stimuli. Yes. So anywhere where there's an extra stimulus, it's ectopic, meaning it's other than where it should be. They're going to burn that place, and it could be multiple ones, right? And so from the conductive system of the heart, yes. So we have the plumbing system, we have the conductive system. Conductive system is the impulses, it's the SA node, AV node. Those are where it's supposed to come. But if it's anywhere else, and we're cutting that circulation, we're going to ablate it, not circulation, that stimuli. So we're going to burn it. Good job, guys. Let's see.
Is there like any nursing interventions we should know, like monitor them?
Oh, that's good. So it's a procedure, right? So they're going to be under, right? Like for myself, they're going to give general anesthesia. So, and then they go into the heart and then they ablate. And when they come out, it's usually a same day procedure where they can leave. So, but see, because they were under general anesthesia, you want to make sure that they're not driving home afterwards. You want to make sure that, when they come out of the facility, that they align flat, that they're not pulling, straining themselves, and they're recuperating properly, right? You make sure that they have gag reflex, right? Because they were under, and all this nerves were, kind of deadened, right? So make sure they have gag reflex, make sure they are NPO before and after, that kind of thing. So all of the pre-op, post-op things are really what we look out for. Otherwise, we're monitoring their heart, seeing if, usually before they have these things, they usually